Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Maryland, Virginia Nursing Home Improvement Network webinar. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments throughout and following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Mr. Harold Hanson. Mr. Hanson, the floor is yours.
Thank you, Laura. I'm Harold Hanson, the Nursing Home Improvement Consultant for Maryland. I'm joined today by the Virginia Nursing Home Improvement Consultants, Linda Harris and David Hall. And on behalf of VHQC, I want to welcome you to today's webinar, Implementing TeamSTEPPS to Improve Communication and Patient Safety. Next slide, please. Before we get started, I have a few housekeeping items to go over. First, today's session will be recorded, and the recording will be emailed to you and also available on our Nursing Home Improvement Network online community. Also, we want to learn from each other, so today's session is interactive. Please participate when questions are asked, either through the polling feature or the chat box. You may also use chat the same questions to Carla. She may not be able to answer it during the session. However, any questions we're unable to answer during the presentation, we will follow up with you after the webinar. You may access chat by clicking on the chat icon in the upper right-hand corner of your screen. And finally, we greatly appreciate your feedback to assist us with future planning. Please take a minute to answer questions that appear on the right-hand side of your screen after the presentation. Next slide, please. Today's speaker may be well known to many of you. Carla Thomas has led VHQC's nursing home projects in the past and now serves as VHQC's Director of Care Transitions. Carla and our Care Transitions team support community collaborative efforts to reduce avoidable hospitalization. Much of what she will discuss today are topics that these coalitions address. Thank you, Carla, for being with us. The floor is yours.
Thank you, Harold. It is my pleasure to join everybody today. Our topic of improving communication and safety through the use of TeamSTEPPS is really exciting to me because it has so many applications. You know, in our hectic work and care environments, strong communication is increasingly critical to reducing unnecessary hospitalizations, improving residents' overall quality of life and care, and even satisfaction. And I, like Harold, also want to encourage you to contribute to the discussion today. Your input will really make this session more valuable for everyone, since some of the best learning comes from each other. Please contribute to the chat session. There will be questions asked of you, and Linda will be monitoring that discussion there for us. We will also have some open time where it will open the lines up for comments and questions. So we look forward to your participation. Today I will talk about the characteristics of high-performing teams and the benefits of leadership, team structure, communication, and situation monitoring for dynamics and teamwork. I will also highlight some communication tools that will help you to improve care processes. As a result of this session, we hope that you will review some of the recommended training and resources to strengthen team building and communication in your setting. We are featuring TeamSTEPPS today. This may be new to some of you, so I'll share what it is and how it was developed. TeamSTEPPS stands for Team, Strategies, and Tools to Enhance Performance and Patient Safety. TeamSTEPPS is a teamwork system designed for healthcare professionals, and it has been proven to work because it focuses on communication and team skills in healthcare settings, and it especially involves frontline staff. It includes a comprehensive set of ready-to-use materials and a training curriculum to really integrate teamwork principles into a variety of settings. So if you're needing some new ideas, these could really be helpful, especially in your day-to-day work and in the work that we work in as well with care transitions. TeamSTEPPS was developed by the Department of Defense's Patient Safety Program in collaboration with the Agency for Healthcare Research and Quality. The curriculum was developed by a panel of experts working with teams in high-risk environments. Now, these teams in those high-risk environments had huge consequences when the errors were great. More than 25 years of research and evidence have been accumulated on teams and their performance in diverse areas such as aviation, military, nuclear power, healthcare, business, and industry. So TeamSTEPPS has really evolved from research in these high-risk fields to the healthcare environment, which is a high-risk, high-stakes environment which, poor performance, really leads to serious consequences or death. So we have placed the link here on the slide for you. This takes you to the main page for the TeamSTEPPS curriculum and tools. We are also adding this to the chat. And a particular note is that there is a nursing home curriculum that has particular tools and exercises and examples for your setting. So based on research, the developers of this program have identified what defines a team, what teamwork requires, how to train team members, and how to manage team performance. The researchers linked team training programs to improved attitudes, increased knowledge, and improved behavior or performance. Within the center of the model, the triangle that you see here, which is part of the logo for TeamSTEPPS, there are 4 key team member skills that are featured and connected in the shape of a plus sign. Leadership identifies key behaviors that leaders need to ensure teams perform effectively with the desired outcomes. Situation monitoring is where team members gain or maintain an accurate awareness of understanding of the situation and where the team is functioning. Mutual support is really involving backup behavior that allows teams to become self-correcting, distributing their workload effectively, and regularly providing feedback. This includes approaches for managing conflict and each team member being part of that safety net. The communication skill development within TeamSTEPPS focuses on how to communicate effectively through some standardized information exchange strategies. And I will be focusing on this specific skill today within the TeamSTEPPS curriculum. The situation monitoring skill set is really the process of actively scanning and assessing a situation to gain information or understanding, or to maintain an awareness to support a team with its functioning. The TeamSTEPPS logo really incorporates all of the important components of a high-performing care team. As you can see within the logo, the outcomes are highlighted in 3 points of the triangle: performance, knowledge, and attitude. With the development of the 4 major skill areas in the middle, a team will accomplish these outcomes as they are all interdependent and connected. The skill sections are needed really to develop a high-performing team so that knowledge, attitude, and performance outcomes can be at their optimum. Since communication skills are the focus of today's section, I'd like to start our focus on communication by sharing a few scenarios with you. We're featuring the technique of storytelling as a powerful tool that can help every team with improvement, and the members of our VHQC team will be helping you. Please be ready to share any of your comments to chat as we will be asking you some questions related to some of these scenarios today. Our first example, Linda is going to be reading for us. Linda?
Thank you, Carla. Beth is taking her mother, Margaret, a long-term care resident who is wheelchair dependent, out for the afternoon to attend a family gathering. As the nurse is signing out Margaret for the leave of absence, she tells Beth, "Your mother is at risk for pressure ulcers now that she uses a wheelchair. Her skin is intact, and she will be fine as long as you reposition her at least every 2 hours." Later that evening, during evening care, the nursing assistant reports that Margaret has an open area on her coccyx. The nurse calls Beth. Beth, sounding confused, says, "How could this have happened? I did just as you said. I turn her chair every 2 hours."
Thank you, Linda. Wow, where did this communication occur in this situation? We'd like to have your feedback about this one. But how often do we assume that our communication is understood by someone else? Reposition the resident versus reposition the wheelchair. In this example, the result of communication was a pressure ulcer, which was painful and costly. And how easy was it for that to be misunderstood? The next example is going to be read by Harold. Harold?
An 89-year-old female resident with Alzheimer's disease has been living at the nursing home for many years. The family decides they no longer want aggressive measures taken and request the resident's code status be changed to do not resuscitate, allow natural death. The evening shift documents in the progress note that the family and designated healthcare agent requested that the resident not be resuscitated. The evening shift does not relay the information during the shift change or on the 24-hour report or notify the attending physician. The day shift does not read the night shift note because of several immediate emergencies. The family, who had been keeping Virgil at her bedside, leaves to go home to shower and eat. Upon return, they find the staff attempting CPR. The resident is successfully resuscitated, but now lies in a vegetative state. The family is very unhappy and considering legal action.
Thank you, Harold. How would you have handled the communication of this resident's condition, and to whom? Please consider answering that in the chat section. Now, this is an example of poor communication which produced devastating consequences. How quickly can critical care communication get missed in the course of a day or shift? I'd really like to encourage you to use these stories with your team and to start conversations about how communication impacts your processes and outcomes. Some things to consider. Is a note in the chart enough if we don't call attention to it, especially if it involves a major change in care? Do you hand over processes at shift change? Do those processes that you hand over at shift change really capture key information? Are the right people getting the information? What are your stories? Really think about how you can make the needs within your team known. And communication is really the lifeline of a well-functioning team. And I will share some strategies and tools that will improve effective communication and sharing information with you. Improving the quality of information really decreases communication-related errors. According to some Sentinel event data compiled by the Joint Commission a few years back, they indicated that ineffective communication was identified as the root cause of 62% of reported errors. Now, that might not be very surprising to some of you, and in fact, you might think that it should be higher. But I wanted to share this quote with you because it's so simple and so true. Have you ever caught yourself thinking or saying, but that's not what I meant? So communication is a response you get to a message you send, regardless of its intent. Communication really facilitates a culture of mutual support. It also is important to really recognize the resident as part of the team and to be aware that clinical and non-clinical people have an important role in affecting the care of the resident. I want to mention two areas that impact communication effectiveness: communication delivery and information exchange. Now, communication delivery includes things like the intended audience, who you're communicating with, and how you're doing that, whether it's written or oral, as well as your delivery technique. which involves how clear and brief you might be. But effective information exchange also involves some specific techniques. Sending techniques are really how you seek information from all available resources, how you are sharing information before it's asked, and providing situation updates as necessary. This technique is really all about team members initiating the exchange of information because your team culture reinforces that. It's not really about waiting to be asked. Now, recurring techniques are when team members really look at some data to analyze and information that is provided and trying to synthesize it so that you can modify the existing plan of care. So are you really stepping back and determining trends, and are you asking team members to think in this way? You know, team members are saying, this keeps happening, or this has happened before. Perhaps we need to do something differently. You want to be encouraging a culture where team members feel free to identify some recurring themes and sharing that information with each other. Now, verifying techniques for information exchange are really about checking information to confirm the intent of the sender, similar to that quote that I shared on the previous slide. So with the story of Beth that Linda shared, verifying her understanding of what turning and repositioning meant could have helped to prevent her mother's pressure ulcer. Validating techniques are confirming the intent of the sender, whether it's orally or in writing. So things that you want to consider with validation is what you mean being conveyed accurately, and is what you're hearing what the person meant. How do you really know? So next we'll share a few more stories, and our storyteller for this example of Jack will be Rhonda Fletcher, who many of you know as our project assistant. Rhonda?
Thank you, Carla. Jack, a newly admitted resident to the subacute unit, is at the nursing home for rehabilitation following hospitalization for an acute episode of congestive heart failure. The dietitian orders a low-salt diet and speaks with Jack and his wife about the importance of eating low-sodium foods and not adding salt to any foods. They agree and say they've been following those recommendations as given by their doctor. Jack says he misses foods such as ham, but is thankful he can still eat bacon.
Well, this may give a little chuckle to some of you listening to this story. Thank you, Rhonda. This is really an example of inadequate verbal communication with residents and families. The validating technique would have worked very well between the dietitian and the resident and family, so that what the dietitian was conveying about low-sodium foods could have been checked for understanding. Some teams use a similar technique and call it teach-back, especially when there's some education that is occurring with patients and families. Now, our last example will be read by Erica Morrison, our Learning in Action Network Manager. Erica?
Thanks, Carla. Christine, a resident who takes warfarin, is noted to have a bloody nose, bleeding gums, and a large bruise on her arm. The nurse reports these findings to her physician. He orders a CBC and an INR and assumes she understands his intent to have these labs drawn stat. The nurse orders the labs to be drawn on the next lab day, 2 days from now.
Thanks, Erica. Now, this is an example of inadequate verbal communication between a nurse and a physician. The verifying technique could have been a key type of communication that would have been critical to the resident's outcome here. Just even double-checking the doctor assumed stat was immediately, and the nurse understood stat to be the next time it was available. How does your team ensure accurate communication between nurses and physicians? We've run that question also in the chat, but we'd also like to open up the lines and ask you, those of you who are participating with us on the line today, what tools and strategies are you using to help eliminate causes of poor communication? Sorry, my tongue got twisted there. Laura, would you like to tell folks on the line how they can comment?
Certainly. The floor is open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. And if at any point your question has been answered, you may press 7 or Q again to disable your request. If you are using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality.
We've been asking a few questions in chat. Linda, do we have any answers at this point?
None at this time.
Okay, thank you.
Ms. Morrison, we do have a question on the line.
Okay, great.
Please state your question, Donna.
Donna Wilhelm from Longview Nursing Home. It's not really necessarily a question, but it's just one of the strategies we utilize at Longview to eliminate a poor communication outcome. Within our medical clinical electronic record, we've developed a flow sheet for people who are on Coumadin. For example, so if they start on an antibiotic, there's this flow sheet that the nurse who starts the antibiotic and every nurse on every shift corresponding has to complete within the electronic record. And it asks, not what is the resident on the antibiotic for? Is the resident on Coumadin? If yes, what is the most recent INR, and when is the next lab level due to be drawn? And is the physician aware that the resident who has the antibiotic order is on Coumadin, and has the physician chosen to either reduce the milligrams per week of Coumadin while the resident is on the antibiotic, yes or no? So that's just one way that we try to keep it fresh in everyone's mind when someone's on an antibiotic, which affects Coumadin, that they're looking at it every 8 hours, that you may be possibly having a negative outcome related to the use of the Coumadin while an antibiotic, which can synergate the Coumadin level. So we just try to keep that line of communication going forward.
Thank you so much, Donna. That's a nice example of how you use your electronic platform to prompt that communication and update of information. Does that prompt people to have conversations during change of shift as well?
Well, our change of shift report is from one RN to another every 8 hours. So the 7 to 3, we have 2 RN charge of facilities on the 7 to 3 shift that meet with the 1 RN supervisor for 3 to 11. And we have it upstairs and a downstairs floor during days when it's heavier with admissions and more order reports and things like that. It's why we have 2 RNs during the day shift hours. And then each one of them meets separately with the RN supervisor coming on 3 to 11. And they actually have a printed out report that has all the nursing notes from the last 24 hours, so that the oncoming nurse not only has their oral report, and they actually write things on that written report of call out the doctor in regards to such and such or whatever, but the nurse always has in her hand the report from the previous 24 hours to know what is truly, so if there's any issues that are coming up with any one given patient, while the expectation is that the nurse reads that report thoroughly anyway, but if there's one question that comes up about one patient, within her fingertips she has that written information from the past 24 hours. And then this occurs with the transition to the 11 to 7 RN charge of facility also.
Wow. Thank you so much for sharing that. It really sounds like a strong system that incorporates a lot of, oral, written, reference information to keep that care running smoothly. Thank you.
You're welcome.
Laura, do we have any other individuals on the line?
We do have a follow-up from Donna. Donna, please go ahead.
I apologize. I thought I was muting my line.
Okay. No
And
problem.
I apologize. If you do happen to have a question or comment at any point, please press the number 7 or the letter Q on your telephone keypad. At this time, it appears we have no further questions or comments.
Thank you again, Laura. And thank you, Donna, for sharing. You know, a tremendous body of evidence really exists to support the efficacy of good communication skills for effective teamwork. But as you all know, it's so very hard to define, and everyone has their own definition and understanding of what good communication looks like or means. This quote is just a little bit more specific, and I thought I'd also share it with you. The things to consider when communicating, and some of this may sound a bit basic, but we're hoping that you use some of this information to either verify your own processes and validate how well they're working, or identify some things that could be improved. So you always need to take into consideration your audience. You know, how might your interaction with a nursing assistant be different from that with a physician, for example? You know, the mode of communication. You know, how are you sending your message? Is it verbal, nonverbal, written? Is it an email, a text? You know, sometimes with the ease of electronic technology, we can create opportunities for wide misinterpretations. You know, what are the standards that you are using associated with your communication? You know, are there certain abbreviations that your organization avoids? Sometimes there are, you know, do not use lists with particular acronyms, abbreviations, words. You also need to look at nonverbal communication that you determine as preferred standards too. You know, really the simple rule with anything as you're considering how effective your communication is, you know, when in doubt, check it out. You know, offer information or ask a question just to make sure that what you are trying to communicate is heard in the way that you intended. So whether sharing information with a team, a resident, or family, communication really should meet 4 standards to be effective. Effective communication is complete, meaning, you know, are you communicating all relevant information? Are you avoiding unnecessary details that may lead to confusion? And do you leave enough time for especially residents and family members to ask enough questions and answer them completely? Are you clear? Do you use information that is plainly understood? Do you avoid medical jargon? Do you use layperson terminology, especially with residents and their families? And you know, really think about the common and standard terminology that you should be using with members of your team. Now, you know, are you brief? Are you concise? Or do you include more information than is needed? Are you timely? Are you dependable? Are you avoiding delays and relaying information, especially if it can compromise a resident's situation? And are you updating people frequently as you need it? So an example of effective communication could be something like a well-written discharge prescription or medication reconciliation. You know, is it complete? Does it include medication, dosage, frequency? Is it clear? Is it written clearly or legibly? Is it brief? You know, does it contain only the necessary information? And is it timely? Is it written before discharge? So that's just a brief example of something that really has all components of effective communication. So we have a polling question that we'd like to post. And I'm going to ask our General Dynamics operator to list the polling question at this time. That's Emily. Before we go into some specific techniques and tools, we'd like to ask you, what information exchange strategies do you currently use the most? SBAR, call out, checkback, handoff, or handover reports, or other. Give you a few minutes to answer that for those who are on the line. Okay, that poll is over, and we should have the results for those who answered that question for us. I have a prediction about ones that I'm assuming might be used the most, so I'm anxious to see the results. Emily, do we have the results yet? No answer. That wasn't the answer I was expecting. But SBAR and handover looks like the next most common answers. Thank you. Okay, I am going to talk right now about some information exchange strategies. These are all listed within TeamSTEPPS under the communication curriculum. And these really are a number of strategies that potentially reduce errors associated with miscommunication or a lack of information. And these 4 strategies are simple. They can be integrated into daily practice and really have been shown to improve team performance. They're situation background, call out, check back, or a handoff, or something that they refer to as I pass the baton. So many of you might be familiar with SBAR. This is a technique to standardize your communication, and it creates a consistent format for information to be sent and received. So when a fully deployed SBAR creates an expectation for information to be sent and received, it really helps team members to communicate, especially about a resident condition. It's easy to remember: situation, background, assessment, and recommendation, and it provides a real concrete process for framing any conversation, especially a critical one requiring a clinician's immediate attention and action. I'll tell you a little background about this. SBAR originated in the U.S. Navy submarine community to quickly provide critical information to the captain, and it provided team members with an easy and focused way to set expectations for what will be communicated and how. And really, I think a number of people are familiar with SBAR because it is also a tool within the INTERACT program, Interventions to Reduce Acute Care Transfers. So situation, what is happening with the resident? Background, what is the clinical background that is relevant to the situation? Assessment, what do you think the problem is? Recommendation, what would I recommend? The section of this particular framework that typically provides the most challenge is the recommendation. And I think sometimes that could depend on the comfort level with the communicator to the receiver of the information. In the work that we've done in our care transitions project, we have seen very specifically some results that are very encouraging. The more that SBAR is used when nurses communicate with physicians, the less we see transfers out of the nursing facilities to the hospital. We've been able to measure that in several of our communities, and that's very encouraging. I think many physicians are starting to expect more organized and consistent framework for the communication they're receiving. And it also can help your team members to organize that information so that it can be clear and concise and timely and effective. Now, we do have a video that we're planning on showing you within the course of this webinar. We've had a slight technical challenge, but you did receive the link to this video in your participation information, and we've also included in the chat. It's only about a minute and a half, but I encourage you to view it with your team and use it to either evaluate how your SBAR process is going if you're using it, and to educate people about the process. It really can be a very valuable resource for you. And I apologize for not being able to show it today, but it works very well on YouTube. And this is just a snapshot of that actual video and conversation within the video. Within the video, the nurse identified herself and the reason that she was calling to a physician. The physician was quickly made aware of Mrs. Smith's deteriorating situation, the S. The nurse provided a background of the diagnosis and all the current labs. The recent assessment of the resident led the nurse to call the physician with her concerns. And the recommendation was initiated by the nurse for additional labs, and a plan was discussed for future care. So, like I said, recommendation is probably a more challenging section. But hopefully this example will be useful to you and your team. Now, call-out is another communication technique that helps members to really verify what was said. Now, this seems very simple, and this example shows an emergency situation. But really, this technique can be used in everyday communication, just to restate what was asked. It seems very natural for it to be in an emergency situation, but it can be very powerful just to double-check that and have the sender of information hear what they're asking back. So simple but effective, especially when critical information needs to be communicated and verified. Now, checkback is another technique. This, like I said earlier, would have been a great technique for Beth. The more commonly used technique within patient education. This would also have been great in our story of Jack, which is bacon and ham. But the sender initiates the message, the receiver accepts the message and provides the feedback, and the sender simply double-checks to ensure that the message was received. And there are a variety of ways of framing a question in a manner which shows respect to the individual with which you're communicating. People have come up with some very creative ways to ask for verification or a check back or a teach back to make sure that they are that their information can be used. So we've seen a variety of methods for this, but please be sensitive to the person that you're speaking with when you're using this technique, so that they don't feel like they're being tested or in a teacher-student relationship that is making them feel uncomfortable. So some examples of this have, especially in patient teaching, have been asking the patient to describe how they would share this new information with their family, and that can give you some perspective on what they are understanding and what they've heard, and help you gauge your teaching or communication if needed. And this can be done not only with patients, but even other staff members and team members that you're working with. Now, a handoff is a technique that can really decrease medical errors through effective information sharing. This is just simply transferring information, authority, or responsibility from one person to another, from one provider to another, but it really provides an opportunity for people to, again, check communication, ask questions, clarify, and confirm what the information is. And I'd like to, encourage many of you to really think about when you typically use handoffs or What we're starting to use is the term handover, which implies a connectedness between one care provider and another, one care team to another, department to another, or shift to another. Handoff can imply I'm done. You can do this, but handover is, I think, a more collaborative term that more people are starting to use. Some similar change in language is that from instead of being discharged, they're using transferring care from one person to another instead of discharge, which implies that collaboration as well. So a handoff includes the transfer of knowledge and information, the response to treatment, recent changes in condition or circumstances about individuals that are being cared for, or information from one team to the next. So authority and responsibility are transferred, and you can check clarity about who is responsible for care and decision-making. So this is a time and a process that is really identified in many root cause analysis of poor outcomes. So I'd encourage you to look more closely to your handover processes within your team and your organization as you're working with others as well. I'd like to ask Emily if she could open the lines again to ask a question of our participants. I'd like to ask, when you typically use a handover, if you have a particularly strong process that is working for you, or what you're finding particularly challenging and how you've overcome that on your team with handovers. You can press 7 if you'd like to comment or share.
We do have a comment or question from Donna. Donna, please go ahead. In regards to the standardized form, as I spoke earlier, it's our shift-to-shift report that we hand back and forth to each other. But I did want to comment on the reconciliation process. We do utilize that in two different manners. We do a medication reconciliation from the home setting to the hospital and then to our facility at Longview to correlate the 3 different medication lists that we have to verify that there's not something that's been left off at the hospital that's vital, that just wasn't that primary care problem while they were in the hospital, but if they would be off of it long-term would cause them to have a problem. So that kind of medication reconciliation is done on every new admission or return from the hospital, and with our own clinical record. And then the other reconciliation processes that we utilize is that every night on our 11 p to 7 a.m. shift, we have our certified medicine aides that assist the licensed nurse go through every clinical record to verify that any new order that had been obtained from a physician that day is indeed on the clinical record. So the certified medicine aide, who has a limited scope during the night hours because, they assist with the 12 midnight oral med pass and the 6 a.m. oral med pass, but they have downtime in between that. So they can check the clinical record, and then they alert the nurse who's on that unit to any physician's order that has been written that day, and then the licensed nurse goes into the electronic medical record to verify that that order did indeed get posted and posted in the manner in which the order was written.
Great. Thank you so much for sharing the use of your MedAid and ensuring that the information is there for team members to use accurately.
Well, I think it's difficult to look at not difficult, but I think you have to look at your staff's ability and what they can do legally and what they can't do, and then to utilize your staff within the best concept of their time. So rather than having the licensed nurse, spend the time looking through all 108 medical records, you're having someone who has the downtime who can just alert the nurse that, because typically on a given 24-bed unit, you might have 8 orders that were written on a given day, so there's 8 clinical records they need to review versus the 24.
Great. Thank you again for sharing.
You're welcome.
Anyone else on the line?
And if you do have a question or comment, please press the number 7.
Okay. So we have no one else at this time. Okay, I'm going to move forward and introduce I Pass the Baton. This is a tool that TeamSTEPPS has developed for a structured handoff or handover. It follows the letters except for the and it enables team members to just follow a more specific script, a little bit more than the SBAR, and it also includes specific safety concerns, as you can see under F. It has some similar components as SBAR, just a little bit more specific. And this could be something to try with new team members. You could use this at shift change, communication with other care providers or care teams. I wanted to make sure that you had this script. And we also have a link to how the I Pass the Baton is used in video format. It's about a nurse shift change report that focused on an unstable resident. And the incoming nurse was given a comprehensive update that really covered the period since she last saw the resident. So it's only a minute and a half. So it is specific to the nursing facility setting, so hopefully you can use that with your team. One of the things I'd like to point out related to communication are challenges. Within TeamSTEPPS, there are many strategies that you can learn to eliminate or decrease challenges associated with communication. And we'd like you to think about what some of the biggest barriers are to communication that really impacts your team's effectiveness. Many of these could include language barriers, especially with non-English speaking residents, and even staff that could impact your communication with them. Distractions are huge in your setting. Emergencies can take your attention away from the current task. We could have other personal distractions. As many of you know, multitasking is a common term used. And lately it seems multitasking is very difficult to do effectively. So that could definitely impact communication. The physical proximity. Many people are virtual nowadays, or they could be in another office, they could be far away from you, and that can impact what people are understanding or communicating. Personality, workload. We're all doing numerous jobs nowadays, and different styles that people have. Conflict gets in the way. And verification, which I brought up earlier in this webinar, just double checking that a person got the information, that it was acknowledged, and that they understood it. Shift change. While shift change is a great opportunity for communication to occur, that can also create challenges with making sure that the information is getting transferred. So that transition in care is really one of the most significant times when communication can break down, even though we use it quite frequently to transfer information. So just some things to think about and hopefully assess in your own team and identify where you might be able to continue to improve. As I wrap things up, I just wanted to share a table from TeamSTEPPS that highlights a few more a few more barriers to team effectiveness. Some of the additional tools besides some of the ones that we highlighted today. Some of those tools are anchored within the other skill areas that can be developed within the curriculum, and obviously some of the outcomes. So today, I just wanted to highlight that just to show you that there are more opportunities and tools to use. So just as a quick summary, I'd like to encourage you and your team to really continue to commit to communicate effectively. Seek information from all available sources that you have. Verify and share information. And practice communication skills and strategies daily. Consider using some of the tools that I've highlighted today. And if you are using them, identify how you can utilize them a little bit more effectively. You know, communication is an important component of your process, and it really supports your teamwork. It can make or break it sometimes. But the skills that you use and that interplay with the leadership qualities of your team, the situations that you're monitoring, and the mutual support that you're bringing to the team can really help a team's effectiveness. We really hope that you would look at some of these tools shared today and assess how you can improve together. At this time, I know that we've sent out a few chat questions and resources for you. Linda, do we have any comments or answers to any of those questions in the chat?
We do not at this time.
Okay. Well, thank you very much. Hopefully, you'll be able to view the videos that we've posted there. And this, again, is a link to TeamSTEPPS Resources. And at this time, I'd like to open the line to see if anyone has any questions about today's session and what we've introduced and what has been shared. And more importantly, if you'd like to share any new learning or ideas that you will act upon. You can press 7 on your keypad. And at this time, I'm going to be asking Emily to post the evaluation questions so that you can answer them while we're highlighting a few reminders in the next slide. Emily, will you be posting the questions for us? They should come up momentarily. At this time, I'm going to turn over the session to Harold today, who has a few reminders for you. I appreciate your participation, and Harold, the floor is yours.
Thank you, Carla, for a really great presentation, and also thanks to Longview for active participation. Donna, I really appreciate that. We posted the evaluation questions, so we'd really like to have your evaluations so that we can make these webinars a lot better for you. And we'd like to also let you know, if you could advance the slide one more, we have a save the date for October 21st. That's the next webinar. And then we'll be sending out a link soon and hope you can join us. I'm also asking that you, if you haven't turned in your QAPI self-assessment, please do so. Here's a link to the SurveyMonkey, or you can just fax the completed form to Rhonda, who you heard earlier today. And on the next slide, we have the link to the Nursing Home Improvement online community. And remember, the resources and links you've seen today and in other webinars are available on this online community. So it would be really to your advantage to make sure you have access, sign in, and get those resources available to you all in one convenient location. And just take a moment to complete the evaluations before you leave. And thanks, everyone. Have a great afternoon.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your line at this time.